All right. Well, hello, everyone. Welcome to tonight's webinar. Tonight, we're going to be covering post-discharge nausea and vomiting in ambulatory surgery. Some of the topics the presenter will cover is how to define the scope of post-discharge nausea and vomiting, how to identify patients at elevated risk, and how to create an evidence-based plan for its prevention. For those of you who are not SAMBA members, please consider joining our society as it does offer many benefits. You can view a list of these member benefits on your screen now. You can visit our website at www.sambahq.org to learn more about these benefits and become a member. A few housekeeping items for tonight's event. So for this webinar, you'll be in listen-only mode. You'll see two buttons at the bottom, a Q&A button and a chat button. The chat button will be used so you can talk with other attendees, and the Q&A button will be to submit questions that you have for our presenter. As an attendee, your audio and video will be off. Dedicated time for the Q&A will take place at the end of the presentation, but please submit these questions during and throughout the presentation so we can prepare an answer. SAMBA is also on Twitter, Facebook, and LinkedIn. So please connect with us on social media to stay up to date with all things SAMBA. Now on to introductions. My name is Dr. Catherine Tobin, and I'm joining from the Medical University of South Carolina in Charleston. I serve as the chair for SAMBA's Education Committee, and in addition to presenting, I'll also be moderating tonight's webinar. At this time, I'd like to introduce Jamie Hyman. Dr. Hyman is an assistant professor and section chief of ambulatory anesthesia at Yale School of Medicine. She also serves as the co-chair on SAMBA's Education Committee. She received her medical degree from Albert Einstein College of Medicine in 2008. She then completed her residency at Mount Sinai in 2012. Following residency, she stayed on faculty at Mount Sinai from 2012 to 2020. Then recently, in September of 2020, she joined the faculty at Yale, and there she serves as the section chief for ambulatory anesthesia. Dr. Hyman specializes in head and neck and ENT procedures and has done research in areas of airway management and outcomes after ambulatory anesthesia, including post-discharge nausea and vomiting. So now I'm going to hand it over to Dr. Hyman. Thank you so much.
Thank you so much, Dr. Tobin, for that very warm introduction. I'm just going to take a moment to share my slides. And all right, here we go. So I'm absolutely thrilled to be talking to you all tonight about this topic, post-discharge nausea and vomiting after ambulatory surgery. It's a topic near and dear to my heart, as Dr. Tobin said, a research interest of mine. And I hope to convince you tonight that it's very important and somewhat under-recognized issue in our practice, especially as ambulatory anesthesiologists. So as mentioned, the learning objectives for tonight are first to define the scope of PDNV after ambulatory surgery, and you may be surprised to find out how common it is. Then to identify which of our patients are at particularly elevated risk for PDNV. And finally, to create an evidence-based plan for PDNV prevention in those patients who are at risk for it. Before I take a deeper dive into post-discharge nausea and vomiting, I want to just give a quick shout out to the 4th consensus guidelines on the management and prevention of post-op nausea and vomiting. These were just published this past summer, and they were a joint effort of the American Society of Enhanced Recovery and SAMBA. And they are very, very helpful in terms of the overall management of PONV. Impressively, the authors went over 9,000 studies that had been published on PONV since the previous guidelines 6 years earlier. One key change compared to the previous guidelines is that now multimodal prophylaxis is recommended for patients with one or more risk factors. So really most comers should get multimodal prophylaxis as opposed to a more risk-based escalation in the number of interventions that you do to try to prevent PONV. And this is because really patients who are being undertreated and with now really cost-effective medications available to us with few side effects, it makes sense to be giving multimodal prophylaxis to most of our patients, depending on the institution that you work in. a couple of new therapies that are in the most recent guidelines that hadn't really been covered before include amisulpride, which is a anti-dopamine agent targeting D2, D3 receptors, which has been shown to be effective both for the prevention and treatment of PONV and is now FDA approved for those indications, as well as palonosetron, which is a longer acting 5-HT3 antagonist. It has a half-life of about 40 hours and has better receptor binding than the classic ondansetron. And rolapitant, which is a newer NK1 receptor antagonist with a very long half-life of 180 hours, which helps with delayed vomiting. So I recommend that you look at the guidelines to get more details about those medications for PONV prevention. And then one other thing I wanted to mention is that these newer guidelines